in Bunbury. We welcome you to this forum in collaboration with Rural Health West, and we see this forum really being the first of a series of initiatives that we're working together on to disseminate rural and regional health research. Some of you may be aware of the upcoming forum in Bunbury in November. With this particular project today, the ORCHID project, the Lishman Health Foundation supported this project with some of the funding and probably was along with the project from its earliest days. So today we're also very fortunate to have with us Professor Gary Gurlhod, who is the Executive Director of the WA Health Translation Network, and Gary's going to chair this session. Before I hand over to Gary, just a couple of housekeeping things. So you're all participants are on mute, but you have a box there to type in your questions, and you may want to do those along the way, and then we will take the questions at the end of the presentation. Gary will take on board your questions. So if you direct your questions to Gary, then he will be able to distribute those across the other panellists. And the other thing is that the webinar will be recorded and distributed. There is a video as part of this presentation, which won't be part of what we're able to provide afterwards. So we'll let you know where it'll be available, the presentation, probably on Lishman website, Rural Health West. But I'm not going to take any more time, so I'd like to hand over to you, Gary, as our chair.
Look, thanks very much, Ty, for asking me to be part of this, and it's very exciting to see research, health research generally, taking shape or growing in country WA. Look, very brief. I'm just going to give a bit of an overview of where I'm from and the West Australian Health Translational Network, and then I will hand over to the panelists who will then speak. Look, my background briefly, I'm a paediatric emergency physician for many years, but for the last couple of years, or for the last 5 years, I've been involved with the West Australian Health Translation Network. First of all, through my role at the health department as CMO when it was being set up, and on the board, and for the last 2 years as executive director. And for those who don't know, basically the West Australian Health Translation Network, it's very comprehensive. It takes all our universities in WA, all our big research institutes, our hospitals, private and public, as well as Path West. And the reason it came into being was probably all stems from the McKeon report. Many people might know from about 2013. That was looking at medical research in Australia. How can we do it better? Many recommendations, but one was to create these academic translation centres. They have different names, but it was based on the idea that on the success of similar centres in North America and in Europe, especially in UK and Canada. And the idea was that, to break down the silos, that you would get better patient health care, but health outcomes, if you combine academia, research, and clinical service. And so based on the McKeon report, NHMRC asked for centres like this to be recognised around Australia, and now there are 10 of these centres. There are 7 based in the cities, and in the second round they created another sort of standard or for regional centres. So WA is very comprehensive here, but there's 2 in New South Wales, 3 in New South Wales, 2 in Victoria, etc. And just recently 1 in North Queensland. So there's 3 regional ones as well, which you're probably interested in. And so basically we've been for the last 5 years trying to bring everyone together, and it's a translation center, meaning we're trying to break down this mythical 17 years between when something is actually found and is published and some positive finding in terms of health that actually becomes standard practice. They say it's 17 years, incredible to think, but our idea is to bring that down. And so just very briefly, our funding, it comes from different places, but some of it certainly is from the Medical Research Future Fund. As you know, NHMRC puts probably about a bit under $1 billion into research across Australia each year. And this new, relatively new fund now matches that. So there's close to almost $2 billion going into medical research now across Australia each year. We're about 10% of the population WA. We only get probably about 5% of that funding. So obviously we're trying to increase that. With the $6 million we got over the last couple of years, half of that we gave to the area health services, and I very strongly insisted that part of that would be available to WACS, you know, to the country service as well, because as you know, they've been trying to make a big effort in recent years to, although they have very good service, to actually increase research as well, and so they've appointed, you know, research, you know, people in the research area, research director, and so on. And in fact, we have, you know, through that, we're funding a study based in Bunbury. So look, that's just a very, you know, sort of broad outline. So I'm really pleased that the Leishman Health Foundation is actually in the Southwest, you know, is really promoting research, funding research, and organising seminars like this. And for those who don't know about it, the West Australian Health Translation Network, if you look it up, it's easy to find. There's all sorts of platforms we have there. There's online training for researchers that's free, generally speaking. We have a consumer and community involvement in research. Again, a resource that's available to everyone, as well as the clinical trials and various other things. So I won't go into detail here, but please look that up. Sadly, our Science on the Swan annual meeting was postponed this year for obvious reasons, but hopefully they'll be back next year, and hopefully people can attend that as well. So look, that's just a very broad outline, just perhaps setting the scene in a very, you know, broad sense. So at this stage, I'll hand over to our speakers and so on. And in the first instance, I'll hand over to Erica. I think it's going to give us a welcome to country, and then we'll move through the talks and discussing the ORCHID project. So thanks, Erica.
Thank you, Diane and Gary, and the Southwest Research Collaborative. I would like to extend a warm welcome to everyone who has joined us here today for this health research webinar. As Diane said, my name is Erica Spry. My Aboriginal bush name is Ribinjan, and I am Judawin's daughter. I'm a traditional owner of the Bardi Jowie Native Title Lands located on the Dampier Peninsula out of Broome in West Kimberley, with family ties throughout the Kimberley to my family in the East Kimberley, the Gidja people in Warman community in Turkey Creek. I am currently the Kimberley Aboriginal Medical Services Research Officer. I would like to begin by doing this welcome to country and acknowledging the traditional owners on whose lands we are presenting from today. Myself and Julia Marley will be presenting from the traditional lands of the Yaru people of Broome in the Kimberley region, and Andrew Kurt and Emma Jamison will join us from Bunbury down south on the lands of the Noongar, Wanagala, Kala, Budja people, and we pay our respects to all the elders past, present and future here today. Diabetes is a metabolic condition that happens when you have too much blood glucose. While we need glucose for energy, too much is toxic and can cause heart disease, blindness, amputations, and kidney disease. Management of diabetes can prevent these complications from happening. Pre-diabetes is when blood glucose levels are high, but less than that of diabetes. Having pre-diabetes means that there is a high risk of developing diabetes in the next 5 years. Both pre-diabetes and diabetes can be reversed by making positive changes to your lifestyle. Every time you have a meal and a sugar-based drink at breakfast, lunch, dinner, and snacks, you bring glucose into your body. High blood pressure or high blood glucose means more glucose floating in the blood. During pregnancy, you need to do an OGTT, the sugar drink test. The glucose attaches to the hemoglobin in your red blood cells. High blood glucose for a long time means more glucose can become stuck to the hemoglobin. The HbA1c test tells us about the amount of blood glucose attached to the hemoglobin over the last 3 months. In 2017 to 2018, 1.2 million Australians had diabetes. In Australia, there are higher rates of type 2 diabetes in areas that have high rates of low socioeconomic conditions. All persons, regardless of their ethnicity across the world, are at risk of developing diabetes. And over to Andrew.
Thanks, Erica. So who is at risk so we had 20 million people, sorry, let's start again. 20 million people with live births impacted by diabetes in pregnancy. And we've seen that it happens when mothers get older. And we're seeing a lot more women now with diabetes in pregnancy. So currently, the figures estimate there's about 1 in 6 pregnancies worldwide are complicated by diabetes. Let me just go to the next slide. Thanks, Emma. So who's at risk? So broadly, we think about diabetes in pregnancy in terms of 2 groups. There's pregestational diabetes mellitus. So that can be type 1 diabetes, that's where you have an insulin deficiency. Type 2 diabetes, where your insulin is not working so well and there's resistance, or some other smaller groups, monogenic or specific diabetes. Then there's a group of gestational diabetes, and we broadly divide that into whether it's pre-diabetes, as mentioned by Erica, or it's a condition that develops during pregnancy. Now, broadly speaking, with the pre-gestational diabetes and the gestational diabetes, we're talking about lower levels of sugar, but they still have complications during the pregnancy. So thanks, Emma, we've got the slide. So that you can see about 16% of diabetes in pregnancy is classified as pre-gestational, which is predominantly type 1 or type 2, and the rest is the milder gestational diabetes. However, it's important to note that half of the women with pre-gestational diabetes don't actually know they have it before they fall pregnant, and it's picked up during pregnancy. Because there's a whole lot of health screening that happens in pregnancy, this is a great opportunity to detect diabetes. We also don't know how many women who are classified with gestational diabetes actually have pre-diabetes at conception. And it's women who have slightly elevated glucose who are likely to go on and develop type 2 diabetes in the future. So even though gestational diabetes and pre-diabetes has implications for the pregnancy, it also has implications for the woman down the track. So who's at risk? You can broadly divide this up into 2 groups. So there's modifiable risk factors, and these are all assessed at your first antenatal presentation. So if someone's overweight or obese, then they are more risk of diabetes. Cigarette smoking, although it doesn't directly relate to diabetes risk, certainly relates to exacerbating the complications of diabetes and complicates the pregnancy. There are psychosocial factors such as depression, and these are a risk because patients who have mental health issues often have poorer lifestyle factors like exercise and diet, and so there's often a direct link with depression and increased risk of diabetes. Unhealthy diet by itself, obviously, and an inactive lifestyle are very much a risk factor for diabetes. And all of those are potentially modifiable, and that's why it's important to assess them early. There's a whole lot of factors that are non-modifiable, and just quickly go through those. So there's ethnicity does count with diabetes. There are certain groups who are at risk, so non-European ancestry seems to increase the risk. Advanced maternal age, as you get older, there's an increased risk of diabetes. Family history, for all types of diabetes, is a strong association with family history. Previous pregnancies, twins or multiple pregnancies, that increases the risk of diabetes. Polycystic ovarian syndrome, which is a metabolic syndrome, which affects your sugar metabolism, also increases the risk of diabetes in pregnancy. And medications, and two examples there are corticosteroids and antipsychotic medication. And generally, if you need those, there's not much you can do about it. You have to stay on them. So you can see, yep. So yeah, they're the risk factors. I think I'm handing over to the Emma, I think.
Right. Thanks, Andrew. So a lot of what we know about diabetes in pregnancy comes from women with type 1 diabetes. So you remember Andrew mentioned women with type 1 diabetes can't make their own insulin, and so they have to inject it. And insulin has many roles in the body, but its most important role is to take glucose out of the bloodstream and put it into cells. On this graph, we have the amount of insulin injected per day on the left and the average glucose levels on the right. Now, through pregnancy, these women were able to maintain their average glucose levels within quite a tight range, but to do so, they had to increase the amount of insulin that they injected, and that increase starts around 20 weeks gestation. Now, I'm going to jump in here and let you know that I have type 1 diabetes. I've had it for over 30 years, and I've also got 3 boys. And by the end of each of my pregnancies, I had to inject twice as much insulin as I was before I fell pregnant. Now, the reason we need to inject more insulin in pregnancy is quite complex. It's due to an increase in the pregnancy hormones released by the placenta and cytokines or messengers sent out from the mum's own fat stores. And these combine to make insulin less effective. So you need more of it to keep your glucose levels within the normal range. Now, earlier, Andrew talked about women with gestational diabetes who develop high glucose levels later in pregnancy. And one of the reasons we think that some women develop gestational diabetes is that their cells that make insulin are not able to adapt. And as a consequence, their sugar levels go up. Now, I want to point out here that when we talk about diabetes in pregnancy, glucose gets a really bad rap, but it's actually essential for the development of the baby. So it's really just about getting that balance right. Too much glucose early in pregnancy, so the first 8 weeks during embryonic development, can actually cause defects in the developing organs, and these are called congenital anomalies. Now, these are rare outcomes, but they can have devastating consequences. In Australia, 3 out of 10 stillbirths or neonatal deaths are due to congenital anomalies. And the newborns who do survive often require surgery to correct the defect afterwards, after delivery. So what we do know is that if women with type 1 diabetes or type 2 diabetes receive preconception care to help stabilize their glucose levels before they fall pregnant, then we can avoid these congenital anomalies. But what about those women who have diabetes but don't know it? They often won't attend for their first antenatal visit until they're about 6 weeks pregnant, by which time their developing embryo has already been exposed to high glucose. So in these cases, it's really important that we improve preconception screening for diabetes in high-risk women. Now, what are the outcomes for women who don't know they have GDM, so sort of milder levels of high glucose? Now, we know that too much glucose during fetal development can lead to big babies. By mid-gestation, babies are making their own insulin, and if they get too much glucose from the mum, they respond by making more and more insulin, and then they grow bigger by storing more fat. Now, this is data reproduced from a large international study called HAPO, and they looked at pregnant women who did not have type 1 or type 2 diabetes, and they had glucose measured after 24 weeks gestation. And they grouped the women into 7 glucose categories, from lowest being category 1 to the highest being category 7. And as the glucose levels went up, so did the risk of having a large baby. So this continuous increase in risk has been seen in other studies, and there's no real clear cut point to define who has gestational diabetes and who does not. High glucose is also associated with other adverse outcomes that are linked to delivering a large baby, such as cesarean sections, shoulder dystocia, and birth injuries. Now, high glucose levels in women with gestational diabetes normally disappear soon after delivery, but these women are up to 8 times as likely to develop type 2 diabetes, with a high rate of progression in that first 5 years post-delivery. Babies are also more likely to become obese, even as early as 10 years of age, and they also have a higher chance of developing diabetes themselves. Now, we've talked about all the bad things associated with diabetes in pregnancy, but it's not all doom and gloom. We do know that if we can manage sugar levels and keep them as low as possible during pregnancy, eat a healthy diet, exercise, we can improve outcomes. We also know that after pregnancy, we can prevent or delay the progression to type 2 diabetes with healthy lifestyle interventions. And I'm mindful of the fact that there may be women in the audience today who are watching this webinar who have diabetes and are pregnant and worried about what might happen. So earlier I mentioned I have type 1. I wanted to share a photo of my 3 crazy boys. In terms of my sugar levels during pregnancy, they were probably the best they've ever been in my life. I was very motivated to keep them low. But my first pregnancy was ticking along nicely. And then at 37 weeks, I developed preeclampsia, which is another one of the adverse outcomes associated with diabetes. I had to be induced and ended up having an emergency cesarean. With my younger 2 boys, I was induced 2 weeks early, which was standard practice at the time, and had normal deliveries with both of them. My eldest was 3.5 kilos, but my next 2 were on the big side, so they were both over 4 kilos. But none of them have diabetes. They're all fit and healthy. They play sport and do sort of grown up doing all the regular things that that kids do. And on that note, I'll hand over to Erica.
So like Emma, who has so kindly shared her story, I too will tell mine in the best interest to share awareness of diabetes, which in my case is my story of having GDM. I am a mother of 4 amazing children. I have 3 sons and 1 daughter. With my 3rd child, my 2nd son, I was diagnosed with GDM between my 24-28-week antenatal checkup. On my personal reflection, I remember the convenience of sugar, food, and drink options that were available at various fuel and store outlets. With advice from my midwife and dietitian, I managed to relook at my diet, rethink what I should eat and drink to prevent and cut down on my sugar intake. I self-monitored my blood sugar by a finger prick point of care measure before a meal and 2 hours after. This point of care every day for up to 6 times per day, I didn't like it, and this scared me as I didn't want to develop full-blown diabetes. At first, I found it hard to accept I had GDM, but with each day's food and drink intake, I learned I really needed to self-care for my unborn baby and myself. Fortunately, with exercise and as I controlled my diet by learning to read food and drink labels of sugar content, I avoided the need for medication. That assisted me to have a normal delivery with my son with my last pregnancy. I managed to avoid GDM. Being an Aboriginal person, I know I am at high risk of developing type 2 diabetes. And after my GDM experience, I know it's important that I work with my whole family to avoid diabetes. My fellow Kimberley regional Aboriginal people are diverse and many, with over 26 different language groups. One common theme for Aboriginal Australians is that we are people that care for our country and care for all families of all ethnicities. One of our mottos, healthy country, healthy people. Across Australia, there are over 350 different Aboriginal people. Unfortunately, over 30% of Kimberley Aboriginal adults have type 2 diabetes. The management of diabetes is a long-term health priority for the Kimberley Aboriginal Community Control Health Services, ACHS, shown in this video. Several factors influence how Aboriginal people understand and manage their diabetes. This includes the effects of colonisation and dislocation from country, lack of trust in non-Indigenous health staff who have limited understanding of Aboriginal culture, and fragmented care with multiple services providing healthcare. This is made worse by low socioeconomic conditions, including overcrowding, poor access to nutritional food, and the undervaluing of traditional bush medicine practices and seasonal traditional foods. We also live in an obesogenic environment whereby health promotion usually targets the individual, not the systems that influence an individual's behaviour. You might have heard about the current inquiry into the cost of food in remote WA communities. This is an example of social determinants of health, things that you can't control, having an effect on your health and well-being. The Kimberley Aboriginal Medical Services are a member-based organisation that support and represent the interests of 7 independent regional Aboriginal community control health services, ACHS. In the Kimberley, our diabetes story begins with the screening for diabetes in 2011 to 2013. The point of care HbA1c study took place. This study showed that HbA1c was better than glucose for diagnosing diabetes for Kimberley Aboriginal people. Then, in 2014 to 2015, in the Kimberley region, the implementation of the HbA1c screening began. During the development of the new guidelines for screening for diabetes, one of the clinicians asked if we could use the HbA1c during pregnancy because there were known problems in completing the OGTT, and this led to the ORCHID study.
Thanks, Emma and Erica. So the ORCHID study stands for the optimisation of rural, clinical and haematological indicators of diabetes in pregnancy. And we like the name ORCHID, and so that's how we came up with that. Sometimes we call it the ORCHID study, but we love it as it is. As you can see from this map, there's large distances between the towns and lower resources and poor health outcomes in rural and remote WA. And this map actually reflects the remoteness, particularly of those Kimberley towns, but even other rural towns. But it also has dotted on it towns where the Rural Clinical School, which was the organisation which has started the ORCHID study. And you can see we are scattered literally right across the state. There are actually a few other towns since this map was developed that we're now involved there. The Rural Clinical School was initially set up along with other rural clinical schools around Australia to train medical students in their course in rural medicine. But subsequent to that, the rural clinical schools have also developed roles in research. And because we are embedded in local health services, where we focus our research on health issues relevant to those rural and remote communities. And we're looking for real possibilities for better outcomes in these communities, even though they're spread across those vast distances. And we can do that because we have staff and infrastructure in those towns. So this particular project, the ORCHID study, started as a Kimberley study. And during the development, we've invited other sites around the state to become involved. So it became a multi-site study right across the state, involving all the different rural communities. I think next slide.
Yep.
Thanks, Emma. So this slide shows the rise of gestational diabetes across Australia. So we've got a couple of lines there. So you can see there's a green line for Australia, and then there's a black line for WA, and pretty much they mirror each other. And this goes back essentially for the last, from the turn of the century. And there's quite a dramatic rise there, and there's a number of factors that feed into that. One of the important factors is adoption of universal screening. So before we had that, and that arrived in WA in 2012, there was a risk-based stratification for pregnant women, and not everyone was screened for diabetes. And it's clear that when we were doing that, we were missing a lot of cases. So we're now picking up a lot more because of universal screening. There have been other changes too subsequent to that. So there have been changes in the guidelines. So ADIPS, which is the Australian Diabetes in Pregnancy Society, endorsed the international guidelines from the International Association of Diabetes and Pregnancy Study Group. And the changes in these guidelines and criteria have meant that more people have been picked up. So there's a bit of a time lag, you can see. The diagnostic criteria changed in 2014. Then there's a lag in WA. It's likely due to the time taken for the criteria to appear on the actual pathology reports. And then it was around 2014 when regional clinicians started to raise concerns that many of the women they were seeing were not actually completing the recommended test, which was the oral glucose tolerance test. There are several social determinants of health that have also contributed to the increased gestational diabetes rate. So if your mother had gestational diabetes while she's pregnant, then your risk of having gestational diabetes increases. And quite probably, depending on your age, your mother wasn't tested for gestational diabetes because of the screening was not universal. And so this can actually go back 2 generations. And there are factors called epigenetic factors now, so that what happened to your mother and to your grandmother can have an influence on your risk down the track. So we're actually thinking about a very long-term impact on communities and populations when we're thinking about diabetes. We'll just go to the next slide, Emma.
Yep.
So this is just, this is probably the starting point for the ORCHID study. This is where we did an audit, just looking at what was actually happening in rural WA. This was carried out in the retrospective study. Was an audit of basically screening rates in the rural communities that we were testing in. And that was in 2013. So it was the year after universal screening was meant to be implemented. Now, recognising there is a lag, and Gary just mentioned that there's a 17-year lag between a new finding and implementation. So maybe we're a bit optimistic with a 1 year. But nevertheless, we found that only half the women were being screened with the oral glucose tolerance test. And there was about the remaining 30% of the women were getting alternative tests, which might have included the HbA1c, but there was still a fifth that had no screening whatsoever. And in the half that did get tested, 14.5% of them had gestational diabetes, which was nearly double the rate that was being recorded for the state at that time. So clearly there was a big gap, in screening, and also in the way we were targeting those at-risk groups. And so the rest of the ORCHID study is really looking at why that gap is happening and what else we can do about it.
So we aimed to recruit women statewide from rural and remote Western Australia, including Aboriginal populations in our study was important. 600 participants completed our study and delivered after 30 weeks gestation. 39% of the 600 women were Aboriginal. Aboriginal women enrolled from the Kimberley, my region, was the second largest numbers recorded in the state. Our Aboriginal women are at high risk of GDM. From these graphs, we can see from our study, Aboriginal women were more likely to be obese, have more children, and have a family history of diabetes. Here we show when Aboriginal and non-Indigenous women completed routine screening for an OGTT during pregnancy and who were diagnosed with GDM. This is the recommended screening period in Australia, the 24 to 28 weeks. As you will note, non-Indigenous women were more likely to be screened during the recommended period than Aboriginal women. And consistent with the audit, non-Indigenous women were more likely to be screened. Some women attempted the OGTT but did not complete it, declined or vomited. Aboriginal ethnicity was the only factor significantly associated with not completing the OGTT. And despite Aboriginal women being at high risk and other studies showing higher rates, there was no significant difference in GDM rates in our cohort.
So these results puzzled us at first. We had expected a much higher overall rate of GDM, or at least an increase in GDM following implementation of the new diagnostic criteria. And secondly, we'd expected to see a higher rate in our Aboriginal women, as had been demonstrated in other studies. And when we looked at 495 women from our study who would have also met the criteria for that large international HAPO study, our GDM incidence was significantly lower than the HAPO study, but our babies were larger. So something wasn't quite adding up. So we decided to investigate. And one thing we did was we looked at the number of women in each glucose category. So you remember I showed you before in the HAPO study that women were grouped into 7 categories, from lowest being category 1 to the highest being category 7. And so this shows the proportion of women who were in each category for the HAPO study. And when we looked at the ORCHID study women, almost half of them fell into the lowest glucose category, and we had very few in the highest categories. So we felt it was like the glucose in our study was shifted down. Now, you'll also remember from earlier that I showed as glucose levels go up, so does the risk for a large baby. So when we looked at our data, we saw that women in low glucose categories, so categories 4 and 5, had over 20% or a 1 in 5 chance of having a large baby. And that risk was only seen in women from the HAPO study in the highest glucose category. So after looking into this in a little bit more detail, we now know the reason why. It turns out glucose is not stable in blood samples, and the reason is that the cells, predominantly the red blood cells in a sample, are still alive after collection, and they continue to burn up glucose as a source of energy. Now, we have known about this for decades, since the 80s. So we use collection tubes that contain fluoride. And fluoride stops the cells from burning glucose, however, it doesn't work straight away. So this is data from 10 ORCHID participants who had extra samples collected at the same time as their glucose tolerance test. Now, when fluoride samples are kept at room temperature, which is what happens in most Western Australian clinics, the glucose drops over the first hour, first 4 hours. That's the red line shown on the graph. In the HAPO study, they actually knew this would be a problem. So they put the fluoride tubes on ice and made sure the samples were processed within 1 hour of the test being done, and that slowed down the loss. In Europe and America, tubes that contain a mixture of fluoride and another chemical called citrate are now recommended for use, and these tubes stabilize glucose immediately. Now, in the ORCHID study, most of our samples arrived 4 hours after collection. And when we went back and corrected our glucose tolerance test results, we found, based on how much glucose we estimated had been lost, we found that 62%, or almost 2/3 of the women who had GDM, were actually told their glucose levels were normal because of a delay to analysis. So having ice available in rural and remote clinics, and actually even in metro clinics for that matter, let alone getting the samples to the lab within an hour, is impractical. Also, even if we put a centrifuge into every clinic, we can't guarantee that midwives would be able to spin and separate the cells away from the plasma immediately, whilst they're having to deal with other patients or clinic emergencies. So we think all Australian clinics should have the option of using the fluoride citrate tubes. Now, when we went back and corrected for how much glucose was lost in the sample because of a delay to testing, the risk profile for having a large baby improved, and it looked a lot more like the HARPO study. And over to you, Julia.
Thanks, Emma. So going back to this graph again, if we use the next one down, so if we use the HARPO protocol, we'd expect to get around 25% GDM. However, in the real world, we end up getting about 13% GDM. If we use the FC mixed tubes, we get probably 35 to 40% GDM. But what everyone's forgetting is that they've just come up with this arbitrary cut point based on a risk of 1.7-fold increase odds of getting an adverse birth outcome. And it fails to take into account this gradient effect that we actually have. So some of the concerns that have been raised around using the FC mixed tubes is around an overdiagnosis of GDM. Next slide, Emma. But we actually need to change away from how we think about GDM and to actually look at it in terms of a risk profile, because the risk is dependent on the levels of glucose, not whether or not you make a dichotomous cut point. If you're below it, you don't have GDM, it's fine. We're not going to look when we're just going to give you the basic information about maintaining for the rest of your pregnancy, and we're not going to worry about your sugars or anything like that. But if you have GDM, we're going to do all these extra things to you, and you now got a high-risk pregnancy. So the other things we need to be talking about is taking away the stigma of having GDM, because a lot of the risk of developing GDM are to do with the social, economic, and social determinants of health, the obesogenic environment we live in. And we need to kind of think about it in terms of more of a family approach, looking at reducing risk from that whole of family, and looking at preconception and in early pregnancy. Next. So where did implementation go wrong in Australia? Well, the GTT is a really complicated test, including the fact that it does last for 2 hours, and there's so many places it can go wrong. Also, the requirement of needing a complicated way of processing the samples were not passed on to everyone else in the clinic. So this was raised at the time that they were discussing whether or not they would take on the HARPO findings and change the criteria. It was raised by pathologists, we've recently found out, but everyone decided to ignore it. Some of the things we've been told is everyone knows about it, so when you get your result, you take that into account. Or if they don't actually know about it, then it doesn't really make that much of a difference. But our results demonstrate that it makes a huge difference. And also we asked a lot of people if they knew about glycolysis, and only 2 out of over 50 knew about it. And they weren't in a clinic environment to be able to take it into account. So there's a whole lot of things that need to be addressed when we're actually looking at implementation. So it needs to be around what's feasible in the real world. So because we're embedded within our when we do our research, we have a lot of people saying that's not going to work in the clinic if we try and suggest things. And you also need to think about the opportunity costs. You know, is insisting on this gold standard test that's difficult to do, has so many places that can go wrong, really worth it compared to maybe doing a simpler test that you might not be as good, but you're more likely to get it done and more likely to pick up women at risk. And the other thing is, like, who's monitoring implementation? Whose responsibility is that? Because it wasn't until we started looking at this that we found all of these issues. Next one, Emma.
So we completed a small study using the FC mixed tubes with Broome Regional Aboriginal Medical Service, BRAMS, highlighted here on the map by the star. We'd like to thank BRAMS for their involvement in the study using the FC mixed tubes, as this was crucial for convincing Kimberley services that we needed to change how the blood is collected. So last year, from September 2019, all Kimberley Aboriginal Community Control Health Services and some Western Australia Country Health Services adopted the use of these FC mixed tubes for all pregnancy OGTTs.
Next one. Okay, so now that we've sorted out about the glycolysis, we could actually go back to what our study was about, which was simplifying screening for GDM and also seeing if we could identify women who are at high risk, but if we could identify them early in pregnancy. So one of the things we were looking at was early HbA1c, and this is where I placed my bets in terms, I thought, of a test being useful. So here we're looking at screening, again, similar to the graph that Erica described before. So women who are at risk of GDM are supposed to do an early OGTT, but Aboriginal women who are more at risk of developing GDM are actually less likely to complete this early OGTT. However, they're more likely to complete the HbA1c and to complete it early. Partly it's because in the Kimberley we have it as part of our protocols that HbA1c is tested in first trimester, and it's done at bookings, so at the first test, rather than for the non-Indigenous women when they completed the HbA1c for the study, they had it done later on to coincide with some other tests. Next one. So because what's happened with COVID, I'm just going to show very briefly some ROC curves. So we use this in epidemiology to work out how good a test is. So what we want to do is maximize, we want to be able to have a test that picks up true positives, people who really do have a disease, and you don't have any false negatives, so people who don't have a disease. So the one on the left with the green, the kind of square one, that's perfect and is extremely unlikely to actually happen. The orange one, the second ROC curve, is more realistic. So you're kind of balancing between true positives and false negatives. So, you know, do you have the, you know, are you really identifying people and you're making sure that you're not missing people? If you get the one with the red line, that's the equivalent to flipping a coin, and it really has no meaning. And then occasionally you can get one where it doesn't work at all. So when we look at the ROC curve for our HbA1c, we get a really nice profile for the Aboriginal cohort. But if you look at the non-Indigenous cohort, it looks like it's the same as flipping a coin. So we have, next one down, so it's the, yep. So we picked a point that gave us 95% specificity, and that was a HbA1c of 5.6 and above. So what does this actually mean in the real world? Next one. So while we've got high rates of GDM, another way of thinking about it is that 3/4 of our Aboriginal women did not develop GDM. And the other ones, well, we originally was thinking about this as being using HbA1c to identify women at high risk of developing GDM. Our thinking has changed over the years. It's taken us to get to this point. And also there's other evidence coming out from other people. And then it's like, well, actually maybe those women that we think have as having GDM when you detect them at 24 weeks actually had pre-diabetes before they conceived. And that's what the early HbA1c is picking up. And so when we look at the risk profile for adverse birth outcomes, this actually plays across, and it also plays across the pattern with non-Indigenous women as well. So women who had a normal OGTT, they had 10% risk, which is the mathematics behind having the 90% large for gestational age criteria. If they had gestational diabetes, then they had a 16% risk of having a large baby. If they had pre-diabetes, it actually jumped up to having 19%. And if they had pre-gestational diabetes, then it increased again. So it does look that having those extra higher glucose levels earlier on in pregnancy is having an adverse effect, more so than what you get with gestational diabetes. Next one. I think that's back to you, Emma.
Thank you. So we know from what Julie's explained that we can use HbA1c early in pregnancy to improve detection of women with pre-diabetes. But how can we improve detection of women with gestational diabetes? Now, again, going back to the issues with glucose instability, the first and most important thing we can do is improve glucose stability. So when we do that, we do pick up more women with gestational diabetes, but we're also identifying those women at high risk of an adverse birth outcome. But what can we do for the women who develop gestational diabetes but decline or are unable to complete the oral glucose tolerance test? What other options do we have? Now, can we use HbA1c later in pregnancy? Well, in the large HAPO study, HbA1c wasn't as good as the glucose tolerance test for picking up women with adverse outcomes. But in the ORCHID study on its own, we looked at whether HbA1c could identify women with gestational diabetes after 24 weeks. And it was okay as a test on its own. But because HbA1c can be altered by anemia or the blood volume expansion during pregnancy, it wasn't as good as what we saw earlier in pregnancy. We can, however, combine a HbA1c result with measurement of glycated albumin. And we were very fortunate to have the Lishman Health Foundation fund this part of the project for us, as well as Diabetes Australia. Now, glycated albumin reflects glucose over 3 weeks. So HbA1c is over 3 months, glycated albumin's over a shorter time frame. And it's not affected by anemia, and it's less impacted by the changes in blood volume. And also for the ORCHID study, we were very fortunate to have in-kind support from Asahi Kasei, the Japanese pharmaceutical company that make this glycated albumin kit. So we combined HbA1c and glycated albumin to stratify women as low, medium, and high risk for gestational diabetes. And this was according to the glucose tolerance test results that had been adjusted for that drop in glucose. Now, I should note that all of the women with gestational diabetes who fell into this low risk group were identified after we corrected the results for the GTT. None of them had GDM by the current method with the unadjusted results. So then when we look at these women to see if they've had at least one adverse birth outcome, we see that the risk for an adverse outcome in the high risk group is almost double the risk for the women in the intermediate risk group. And this holds even after we account for the mother's weight, her age, and her ethnicity. Now, notably also, most of the adverse birth outcomes that occurred in the intermediate risk group were in women who would have tested negative anyway by the oral glucose tolerance test. And we're in the process of validating this risk stratification strategy alongside OGTT collected into the fluoride citrate tubes, the tubes that stabilize glucose immediately. And we were very fortunate to receive funding from Diabetes Research WA to do this. Now, if these cut points that we've derived hold, we believe we could use HbA1c and glycated albumin to eliminate the need for an OGTT in the low-risk group and the high-risk women, and just focus on completing a glucose tolerance test in that intermediate group. Back to you, Julia.
The ORCHID study has quite clearly demonstrated that the GTT is failing rural and remote women. We have an underdiagnosis of 62% due to glycolysis, the way we're doing processing our tubes. If we use early HbA1c, particularly for Aboriginal women who are at high risk, we can identify a high risk group early in pregnancy, so then we can start looking at management of this group. And then combined, HbA1c and glycated albumin can safely stratify risk for later development of GDM. And you've already mentioned about the
Okay.
So where to next? We have our audits ongoing to revalidate the early HbA1c and the impact of the FC mixed tubes. Emma and I have in place the ORCHID Study Phase 2 study packs across our sites in Western Australia, again, for revalidation of the HbA1c and the GA cut points. This funded by Diabetes Research WA. And as you can see, we're not short of ideas, and we are exploring preconception care as a whole of family prevention, screening for type 2 diabetes, pre-diabetes, and encouraging a healthy lifestyle for everyone. Prevent pre-diabetes, management of pre-diabetes in pregnancy. We need to look at the timing of when to start management. How do we manage pre-diabetes? What targets should we be aiming for? And is this management effective at reducing the risk of adverse birth outcomes? And what becomes of the GDM, mother and baby long term? We need to ensure that ongoing care is available to the GDM mother after birth and for the baby. And on wrapping up, we would like to again acknowledge and thank all the wonderful midwives and clinicians whom are assisting us with our study.
So I'd like to acknowledge everyone who's taken part. So there was over 27 clinics involved in this study. It's been a huge study, and Emma and Erica have done a fantastic job of project managing the study. It's been quite a complicated study that got even more complicated as we went along. But we've also made sure that we've started implementing things as we've gone along as well. We don't wait for the 17 years gap that other researchers complain about. We actually start implementation usually before we start writing the papers. And it does also demonstrate that you can do cutting edge research in the bush. I'd also like to thank the clinical investigators and all of our funders as well.
We'll just leave up a slide with some useful and trusted resources for diabetes in pregnancy for anyone in the audience who wants more information.
Yeah, can I just comment? Look, that's fantastic. And obviously, there's a lot to get in there. We're hoping to take questions from the audience, but I think we might be a bit short of time. But let me say what I said right at the start. I think this is such a great illustration of what the McKeon report was saying. That is, if you combine clinical care with sort of academia research, you get better patient care. And this is fantastic work where if you were just, as happened in the past, just literally following on what everyone else did, somewhere maybe down south or overseas and that, you find, you would have had all these unknown or, problems, for women in the Kimberley, especially in the Aboriginal population, that you wouldn't be aware of. So to actually pin that down and now actually to be feeding it back, because I think this has implications well outside of just, country WA, if you like. It's fantastic work. So, look, congratulations for everyone. Di, did you want to comment at this stage?
I think we're right on time, so to finish there, but can I thank the team at the Rural Clinical School for collaborating with Rural Health West and Lishman Foundation to provide this today, and, you know, to give other people the opportunity to hear about this, you know, really groundbreaking work that, as you say, happens in the bush. And yeah, thank you to you too, Gary. And as I said, this is really the first of more things to come in the way we tell everybody about some of this great work. So watch this space.
Thanks, Di.
And up there, yep. Thanks, Gary, and everybody.
All right. Well, look, thanks to everyone who came online. I didn't see any questions come up, so I'm not sure if you're shy or whether it was a problem with technology. But certainly, if that was the case, we'll look into that next time. And look, I think you've got everyone's names there, and people who want to follow up and get more detail and so on, I'm sure these people would be very happy to be contacted. So congratulations once again, and we'll leave it at that. Thanks very much.
Yeah, thank you, everybody. Thanks, Gary. See you around. All.
Thanks.
Yeah.
Thank you.
See you, Julie and Erica, and I'll see Andrew and Emma and Bunbury sometime.
Oh, wonderful. See you then.
Yeah.